All right, so we're going to get started on our first plenary session. Welcome back. I hope that you enjoyed the first of our 5 collaborator showcase sessions. Hope you got to get a taste of some of the great science that is being presented throughout our community, and you'll have much more opportunity this afternoon to continue on that space. George actually highlighted in his opening that we are thinking a lot about trust in science. And so this plenary specifically is going to focus on why network studies are necessary to improve trust in evidence. And to frame this up, I just want to get you all thinking critically about what does it really mean for us to talk about reliable evidence. We say this phrase, reliable evidence, all the time, but I want you to be getting a working knowledge of what that could mean for purposes of this session that Martijn, Asieh, and Cindy are going to lead you through. To start a straw man of what that could be, since we're in 2025, I guess we could just ask an LLM, what is reliable evidence? And if you were to ask Gemini, you'd see that reliable evidence says in medicine, reliable evidence is information derived from rigorous scientific research that minimizes bias and can be reproduced or replicated. The most trustworthy evidence comes from study types ranked highest on the hierarchy of evidence and published in authoritative, peer-reviewed medical and scientific literature. Gemini then goes on to describe the hierarchy of evidence, saying very explicitly, the highest level of evidence is systematic reviews and meta-analyses. And it says, considered the strongest evidence, these studies use rigorous, systematic methods to identify, appraise, and summarize all relevant studies out of a specific clinical question. And a meta-analysis goes a step further by statistically combining the results of multiple studies for a more precise estimate of the effect. It then goes on to say that below that in reliable evidence is actually studies themselves. We've got randomized clinical trials and we have other observational studies. You see an evidence pyramid like this, and I don't know about you, but as a person who does observational studies, I always hate seeing these pictures and seeing that we're always sandwiched in the middle of this evidence pyramid. So today, we're going to try to think about how we could move up this pyramid. And the focus particularly today is going to be how can we learn about what's going on at the top of this pyramid with meta-analyses. So to be the best, we got to learn from the best. And this year I've spent a lot of time trying to learn about what's going right with meta-analyses. And this is a screenshot of the Cochrane Handbook for Systematic Reviews of Interventions that provides a lot of guidance about what is this highest quality of evidence that's going on and how you can think about synthesizing evidence from disparate sources to produce something that we hope would be more reliable. Now, I gave you an LLM definition, but I'm going to give you my own working definition of reliable evidence, which is trying to riff off some of those same ideas, just not with a vomit string of text. I'm going to assert that reliable evidence is accurate, precise, and consistent estimate of the average treatment effect of an exposure in a population of interest. So by accurate here, I mean low probability and small magnitude of bias. By precise, I'm talking about having a high certainty around an effect estimate. And by consistent, I mean little heterogeneity in the estimates across a network. I would assert that if we could somehow figure out a way to be accurate, precise, and consistent, then we might be on our way towards actually having reliable evidence. But this session is about network studies, so I want to actually assert why am I conflating meta-analyses and network studies? Well, in our population level estimation use case, a distributed network study that we conduct in OHDSI is the application of rigorous systematic methods to estimate a causal relationship between an exposure and outcome within a population of interest. We have a study protocol that we collaboratively develop to define the research question and pre-specify all the analysis decisions. We have a study package that we develop to implement the study protocol specification. We have participating sources that execute that result and generate against their standardized data and generate standardized aggregate summary statistics. We've got somebody who compiles those aggregate summary statistics together, and we conduct meta-analyses performed against the combined data to synthesize the evidence into a more precise estimate of the effect. And together as a team, we collaboratively interpret, summarize, and disseminate the evidence. And so I would assert that when we talk about OHDSI network studies, one could argue, yeah, it's just another observational study, or another reasonable thing to argue would be that actually this is the same best practices at the top of that evidence pyramid when we talk about a meta-analysis. Since our OHDSI eye care and vision research work group is so active, today we're going to run a refraction test, and this is where I'm going to need you to have your phones out. What I'm going to do is I'm going to present you a series of network studies. They're going to look like this. You're going to see network studies with multiple database estimates combined together with a meta-analysis to produce a composite result. So you're going to see the database name, what kind of data it is. You're going to see an effect estimate out there on the x-axis. You're then going to see a random effects is that little diamond at the bottom representing the composite answer. You're going to see two of these studies side by side. You're going to be asked the question, which study do you think provides more reliable evidence? You ready? Got your phones out? Your test number one is which of these two studies do you think provides more reliable evidence? Study one, on the left-hand side, single database. It's a US claims database. It's produced a single estimate, and you can see the point estimate and the confidence interval there. Study two, on the right, 4 databases. They're all US claims, and you can see that instead of just having that one answer, you now have 4 estimates, which means that you've got that diamond at the bottom representing the composite answer with more precision than the first study. So, I'm going to ask you to go to pollev.com/PatrickRyan800, scan that QR code, and you're going to actually get to this screen, and I need you to vote, is study 1 more reliable than study 2? Is study 1 equally reliable to study 2? Or is study 1 less reliable than study 2? Okay. So you should be able to be voting now, and I'm going to give you 30 seconds to go ahead and vote. I'll give a little bit more time. Thank you, Craig. I'd like to be George Ripsack, but still aspiring. All right, give you guys, let's make sure that you all raise your hand if you're done voting, just because this one time I want to make sure everybody gets in. After this, it'll be faster, but the first time it takes some people a bit to get there. So raise your hand after you've voted. All right, what am I seeing? All right, keep going, keep going. All right. All right, I'm seeing about 70% of hands up. So I'm gonna say that this is where we're at. So study 1 versus study 2. 90% of you think that study 2 is more reliable than study 1. And some of you thought, or 5% of you thought study 1 was better. 5% of you thought it was equal. Okay, very good. I'm gonna toggle to the next question, and I'll make it big on the screen so you can see it. So now, left to right, study 2 is that same study you just saw for US claims databases with that composite estimate. Study 3 now has the same estimates, but notice that the source of the data is different. Rather than 4 US claims databases, you now have 1 US claims, 1 EHR, 1 Dutch EHR, 1 Korean claims. Okay? So I want you to vote, which of these 2 studies do you believe is more reliable? Should be able to be here. You're looking at study 2 or study 3. Which of these 2 do you think is more reliable? Okay. Starting to settle down a little bit, but here we don't have as much agreement. We're seeing about 78% of you are saying that study 3 is more reliable. 19% of you are saying it's equally reliable, and 4% of you are thinking actually study 2 is the way to go. Okay, good to know. We're going to go to the next one. Now we're shifted over study 3, that 4 database study with claims EHR, US, Dutch, and Korean. That same study 3 you just looked at. But now I want you to compare it to study 4. Same sources of data, but now you're seeing that the estimates are quite different. And that composite estimate at the end, that triangle at the bottom, is spread out a bit. So which of these 2 studies do you believe is more reliable evidence? Go ahead and vote now. Study 3 or study 4?
Martijn doing study 3 or study 4?
Both.
Quite literally, Martijn made both of these graphs, so I guess we will take that confounder out of the equation. All right. So this is interesting to see. You know, Martijn, I did role play this quite a lot, but didn't actually expect this. So this is interesting to see. So 37% of you think that study 3 is more reliable than study 4. About half of you think that these two studies are equally reliable. And then 15% of you actually think study 4 is more reliable than study 3. So here's a situation where maybe we can learn something together as a community about like how to think about that kind of situation. All right, next test. Now I'm switching to two totally different studies. So we're outside of this context. Study 5 is a 2-database study. Both databases are US claims. Both individual database estimates are statistically significant, and you see the meta-analytic result. Study 6 on the right, you now have 4 US claims databases. Each individual study is not statistically significant. However, the meta-analytic estimate at the end is identical to the first study. So the two studies have the same meta-analytic result. One's got 2 databases, one's got 4 databases. So go ahead and vote for that one. Okay, so about 2/3 of you think that study 6, the study that had 4 databases to produce the composite estimate, is more reliable than study 5. But 18% of you actually think that study 5 is more reliable, then another 18% of you are feeling like they're equally reliable. Okay. Interesting. Next test. All right, 2 different studies. Study 7. We've got 4 databases. You got US claims, US EHR, Dutch EHR, Korean claims. You've got these 4 estimates over on the left-hand side, relatively consistent, producing a composite meta-analysis shown in that diamond. Right-hand side, study 8, same 4 databases, same composition, have estimates that are there, and you see the diamond there. So I'm asking you the question, which of these 2 studies is more reliable evidence? Let's see how you guys are voting. Okay. Interesting. So we got about 10% of you that think that study 7 is more reliable, about 10% of you that think study 8 is more reliable, and about 80% of you actually think that these are equally reliable. And indeed, in this one, those were the exact same effect estimates. We just shifted them to the left. So in terms of reliability, we want to make sure that we're drawing a distinction. Today, we're going to be talking about reliability of evidence, how confident you are that you're finding truth. We're not talking about the magnitude of the effect. So indeed, this was a little bit of a trick question. You guys aced the test. Well done. Last one that I want to test you on, study 9 versus study 10. You got 4 database estimates. Database 1, 2, 3, 4. One of them produces a statistically significant increased risk with a composite estimate. Study 10, same 4 databases, same estimates. We've just changed the order in which we're showing them. Meta-analysis is identical. Which one of these is more reliable evidence? Go ahead and vote. Perhaps I may have given it away. All right. Most of you think that these studies are equally reliable. A couple of you are still questioning it. Well, that's pretty good consensus. I actually want to highlight this, though, because here's where I'm going to draw a connection between why we're up here talking about network studies and meta-analysis versus individual observational studies. Because I told you that the meta-analysis at the end is the right answer, and they're identical in this case. But let's think about if we were to publish individual studies. Some researcher who happens to have access to database 1 goes ahead and publishes their individual study, and lo and behold finds a 4-fold increased risk. Now the world's panicked because we're worried about a large increased risk. Subsequently, studies get published one at a time in temporal order, and we actually learn that we attenuate that risk, and maybe we don't even know if the risk is true at all. That's a quite different scenario in the world than the scenario where we see a whole bunch of null estimates and then somebody produces that 4-fold risk. We might not be as alarmed in that second temporal order, unless those people who produced those null studies didn't bother to publish them. And indeed, we know that non-reporting bias is a major issue. So what we're going to be arguing for today is why we as a community need to be doing network studies, need to be doing meta-analytic estimates so that we can actually ensure accuracy, precision, and consistency as we go through this work. And so with that motivation, I'm going to hand it over to Martijn, who's going to explain to you why there's a path forward for us as a community.
Thank you, Patrick. And thank you all for having me here. It's an honor to be on this stage again. So I will be talking about the value of doing network studies, mostly as compares to doing single database studies. And the reason why I'm talking about this is that I do think we need to be improving the trust in our evidence, as George was saying this morning. And one way to do that is by increasing reliability by doing these network studies. So for that, I will be talking about 3 properties of evidence. And before I continue, I will mostly be talking, or actually exclusively will be talking about effect estimation, and mostly drug safety and drug effectiveness as our use case. And so that's where these principles apply. But I think most of them will also apply to characterization and some of them even to prediction. So I want you to keep that in the back of your head, that it's not just about estimation. So let's talk about the 3 properties of evidence that Patrick also mentioned. Accuracy, which I will define as the extent to which our estimates are unbiased. So this is about how much systematic error our estimates have. Precision, which is the magnitude of statistical power, or in other words, the random error that we have. And this is something you can think of that we express in our confidence intervals. And then finally, I think we're sort of introducing a new concept, consistency, which is the level of agreement of estimates across either different populations, so then we're talking about heterogeneity of treatment effects, and different designs and design variants, where we're thinking about sensitivity analysis. And so what I'll do in my talk is I'll go over these 3 properties as they apply first to within a single database, and then I will circle back and I will talk about all 3 as they apply to a network of databases across databases. So let's start with that first one, accuracy within a database. And this is the topic that we've actually done the most work, I would say, in terms of methods in OHDSI. Like we've stood on this stage before many times talking about how we can improve the accuracy of an estimate from a single database. You've heard us talk about advanced methods to minimize bias, such as large-scale propensity scores and self-case series with spline adjustments. Also, more recently, we talked about objective diagnostics that we use to detect and blind bias results. And just to call out some of them that will be more familiar to you, covariate balance, equipoise between populations, and the use of negative controls to find if there is more residual error, systematic error than we might want to allow. In addition to that, for any residual bias, after applying these diagnostics, we also argue for empirical calibration to take into account this residual bias. And so I think we're in a good spot when it comes to accuracy for a single, within a single database. So let's move on to precision within a single database, which we express, as I said, by the width of our confidence interval. So we prefer a tighter confidence interval usually because that tells us more about the magnitude of the effect. We also compute the minimum detectable relative risk as an expression of the power that our study has. But we also agree with Hernan that even an underpowered study can inform on the magnitude of effect. So even if your confidence interval is wider, you still learn something about where the effect might be and where it's probably not. But ultimately, in a single database, precision is fixed because the data has already been collected. You just have what you have in your data, and you can't choose to go out and recruit more patients. Moving on to consistency within a database. Here we can think about two things: consistency across subgroups. So this is about heterogeneity of treatment effects, and consistency across design variants. So sensitivity analysis, where we want to evaluate the robustness of our findings. There has been quite some efforts across OHDSI to look at heterogeneity of treatment effects, and more interest to do more work on this. I'm highlighting here 2 papers that we've published in the past. And in this case, finding consistency or lack of consistency is neither good nor bad. It's something you want to evaluate and measure, but you don't have a judgment on it. I would also encourage everybody to go see Cindy's lightning talk in session 2, where she'll be talking about heterogeneity of treatment effects as measured in legend diabetes. We can also talk about evaluating consistency across design variants, and anybody who's been involved in a OHDSI network study knows that we often run multiple design variants to answer the same question. So often we run cohort method and self-controlled case series. Often we include different times at risk, or we do other small variants of our design. And if all of those produce the same estimate, then we feel assured. But if they start to give different answers, then we become wary because, well, they can't all be right, so is maybe one or more of them biased? And so we still, I think, have a lot of research to do in how to deal with these inconsistencies when we do these sensitivity analysis. But I would like to call out Schuemie's poster, where he actually already has done some research on how we can average across these different models to produce a single estimate, where we acknowledge the uncertainty that we've now discovered. All right, so now we're moving on to the row where we talk about across databases, about these properties. And so moving on to consistency across databases. Oops, sorry. Now we have a new opportunity to evaluate heterogeneity or consistency, which is the heterogeneity and consistency between databases. And here, this can also help us evaluate the accuracy of our results, in the sense that observing the same effect in all databases increases the credibility and generalizability. And I think we also saw in the poll that most people share that intuition, that if you have lots of heterogeneity, then we tend to trust the evidence less than when there is more consistency. However, there are also different reasons why results could actually not be consistent in a database network. These are the reasons we also mentioned before. So there could be effect heterogeneity, but now it's a little bit more subtle because that only leads to different estimates per database if the populations within those databases also differ. So we need both the populations to be different and there to be treatment effect heterogeneity. And so, for example, if we compare the Medicaid database, which has a younger population, to the Medicare database, which is mostly an older population, and the effect differs per age, then we will see inconsistency, but that's just because that is the truth, because the populations are different. The challenge here is that we might not know what these effect modifiers are. In my example, it was just age, and we might not even be able to observe that effect modifier. So instead of age, it could be a genetic modification, a SNP, and that's not something that we readily observe in our data. The second reason why we could see inconsistencies across the network is if the data capture and health processes are different between databases, because then the systematic error could be different. So for example, one database might just have more measurement error of the outcome and therefore have a more biased estimate and therefore show a different answer than another database. Or it could be that one database has a different prescribing process behavior than another database. It could be different healthcare systems, different countries even, and then we could have different confounding by indication leading to different answers. Again, in many of these cases, we might not know what the causes are of these inconsistencies, and they might be due to reasons that we don't observe. And also, we cannot often distinguish between these two causes. We can't tease them apart as easily as we could within a single database. So, in a sense, we have a problem here, but there is an asymmetry there in that if we know for certainty that the consistency is high, then both reasons must be absent. So we might not worry so much about reason 1, but reason 2, of course, is a real concern. But if we observe no inconsistency, then there can't be any difference in systematic error, and therefore we feel more confident in our result. So how do we measure inconsistency between databases? Well, many of you are probably familiar with random effects meta-analysis. In a random effect meta-analysis, we explicitly do not assume that the effect is the same in every database, but instead we assume that the true effect in every database draws from a distribution, and usually that's a normal distribution, as I was showing here in the bottom. Or, and maybe in a little bit more cartoonish way to show the same idea, in a network where we have multiple databases, in every database we have a population of persons. And across that population, we then estimate the average treatment effect across all those persons. But then we can combine those averages, and now we have basically a population of averages, and then we can compute, for example, the mean and standard deviation of that distribution, which we'll call mu and tau. And so these random effects meta-analyses assume we draw from usually a normal distribution with mean, mu, and standard deviation tau. And the interpretation that we can give to those two numbers is that mu tells us about the average effect across databases, because it's literally the average of the average treatment effect. And tau can inform us on heterogeneity, the inverse of consistency. And so we can use that as a measure for inconsistency. And so typically, if you look at a forest plot showing a meta-analysis, you do indeed see not only the estimate of mu, which is really just the meta-analytic estimate of interest. So that's, in this case, the 1.20. But you also often see that we mention that there is a tau and what its value is. Many of you might be more familiar with the I-squared measure of heterogeneity. I-squared is the proportion of the total variance that's explained by tau. And as a consequence, it means that the I-square will increase as sample size will increase, as your precision increases. And that's not a property that we think is very helpful for what we're trying to do, because like heterogeneity shouldn't be a direct function of sample size, and therefore we prefer tau. In this specific example, there is lots of heterogeneity in this plot, and therefore the tau value is pretty high at 0.6. In this other example, this is actually one from the poll that you just did. There is much more consistency, and therefore tau is lower at 0.12. So what kind of tau values do we actually observe in OHDSI studies? Well, for that we're going to go to the legend hypertension and legend diabetes studies. So for those of you who are unfamiliar with these studies, these are very large OHDSI studies that we took where for each of these two indications, we compared all the treatments. So all treatments for hypertension or all treatments for diabetes. And for each pair of two treatments, we did a comparison. And we looked at a large set of safety and effectiveness outcomes, meaning in total we had tens of thousands of target comparator outcomes where we produced estimates across a network of databases. And for all of these, we followed the OHDSI best practices that I just mentioned, including using large-scale propensity scores, using objective diagnostics, and calibration. And so it's nice that we have these data sets, these result sets, because they're basically a large sample of network studies that follow the OHDSI best practices. And so that's what we'll use it for today, to see what heterogeneity and other things look like. So we can compute tau in Legend. So in Legend hypertension, we had 20,000 target comparator outcomes at the drug class level in 9 databases. For Legend diabetes, we had 746 target comparator outcomes at the class level and 14 databases. We removed estimates, failing diagnostics, and we restricted to studies that had at least 6 for hypertension and 9 for diabetes databases passing diagnostic. I wanted to have enough databases to be able to accurately measure tau. We performed the meta-analysis for those target comparator outcomes, and then we take just the estimates that we produced there of tau for each of these meta-analyses. We took the posterior, which is basically just expressing also how uncertain we are about tau, and then we average across those to produce the distributions that you see here. So here you see that on the x-axis is the tau value, and on the y-axis is the density, basically the probability of that tau value being the tau value observed. And you see that overall for these legend studies, tau is actually pretty low. So the peak of these distributions are at 0.05 for tau. And to give you an idea of what that means that 95% of the effects in these studies are within plus minus 10% of the mean of mu that we estimate. So that's very little variability. Also, to give you a better idea of how these tau values compare to others, these vertical lines are from a random selection of Cochrane studies, the tau that they report. And so as you can see, they sometimes report tau as high as 1.2. And that's far from the distribution that we observe. So that's good news, and I attribute that to, in large part, to the fact that we do a good job of getting high accuracy within a database. We also do see that there is still some inconsistency left. It's not a lot. As I said, it's hard to tease apart if that's due to true differences in the effect heterogeneity, or due to different systematic errors. But we can actually get a good approximation of that by looking at the negative controls only. So here in red, I'm showing you the distribution of tau values just for the negative controls. And to contrast that, and of course, I have to explain, for a negative control, by definition, there is no true effect. And therefore, by definition, there can be no effect heterogeneity. So we know that the only type of inconsistency that you see for negative controls are due to differences in systematic error. And to contrast with these negative controls, I then selected outcomes of interest, and I specifically focused only on those where the meta-analysis showed a significant effect, just as a selection where we believe that there's the highest probability of actually being a true effect, and therefore the highest probability of there being effect heterogeneity. And so that's shown in blue, and it's actually pretty hard probably for you to see the two colors, just because these two distributions are right on top of each other. So I think that's very interesting, in that it seems that what little heterogeneity we have left in these legend studies apparently mostly is just due to small differences in residual systematic error, and not so much due to differences in effect heterogeneity. That's not to say that there is no effect heterogeneity in these effects, because as I mentioned earlier, you also need the populations to be different to actually lead that to differences between database estimates. But overall, I think this is an interesting finding. So moving on to precision across databases, what is nice here is that within a single database, the precision is fixed. You just have the data that you have, but within a network study, the amount of precision that you have is determined by the number of databases that you include, and therefore you can choose to basically get more precision by including more databases. And I was just talking to other Cynthia about this, that you can actually, our recommendation is you can actually plan ahead before you do the study and see whether you think you have enough power to achieve or to measure the effect that you're interested in. So this precision is no longer fixed, and we can actually, before we start the study, we can choose to plan for having enough precision, given certain limits, obviously, of what data is available. And so what could we achieve by including more databases? And for that, I'll go to the OHDSI Evidence Network. This is a OHDSI community effort led by Claire Blacketer. That's trying to create a network of that ensures the quality and integrity across the databases. and also has collected summary statistics across the OHDSI evidence network that's held securely at the OHDSI Coordinating Center that's used to inform network studies. And so these are the 45 databases currently in the OHDSI evidence network. Thank you, Claire, for the table. I'm not going to go over the whole table, just if you can see the rightmost column, that is the number of patients in each database, and you'll see that that actually changes quite a bit. So some databases have like thousands, and others have hundreds of millions. Lots of different power between these databases. And we actually try and quantify how much power we have in the OHDSI evidence network, because we know when we look at the data that was collected, we see that there are 5,000, almost 5,000 ingredient concepts across all indications, so not just restricted to hypertension and diabetes, that appear in at least 2 databases. So these are drugs that we could say we could study in a network study. For each of those, from the OHDSI evidence network, we know the number of patients exposed to each drug. And using that, we can approximate what the minimum detectable relative risk, or MDR, will be at a power of 80% and an alpha of 0.05. We do need to make some extra assumptions. One is that we know that what the prevalence of the outcome is, and we know what the comparator size is, which we'll here we'll just assume is of equal size as the target. So for example, for tirzepatide, we know that in database 21, we keep them anonymized, not to single out a specific database. In database 21, there are 4,730 patients exposed to tirzepatide. If we assume that the outcome is rare, which according to the SIAM's classification is 1 in 1,000, we can approximate the MDRR to be around 6. So the minimum detectable relative risk for database 21 for this drug for a rare outcome is 6. So any smaller effect, if we want to be able to detect it, we would not be able to do it with just the data in this database. Database 30 is a bigger database. Here we have 15,000 people on tirzepatide. That gives us an MDRR of 2.73, which might be enough, but might not be enough. If we look across the entire OHDSI evidence network, well, we see we have 2.6 million people on tirzepatide, meaning we can have a MDRR of 1.08. So that's certainly sufficient to answer many questions with high precision. We're looking at another drug, empagliflozin. We see that database 21 has a little bit more patients here, so we have an MDRR of 2.35. Database 30, again, is a little bit bigger, so already has an MDRR of 1.48. So already we could do a lot within database 30, but across the entire network, we have 10 million people on this drug, and a minimum detectable relative risk of 1.04, so very high precision for high reliable evidence. So we computed this for all drugs and all databases, so just showing here on the x-axis the minimum detectable relative risk in a medium-sized database, just to illustrate. This is just a histogram, so the number of drugs within each bin is shown on the y-axis. You immediately see that in this specific database, which is a medium-sized database, like most representative therefore of most of the databases that we have, in this database, most of the drugs by far are in this last column, which is actually at infinity, meaning there was no data in this database on these drugs. And so if I add 2 lines here at MDRR is 2, I would argue if the minimum detectable relative risk is lower than 2, then we can probably show clinically relevant effects. And so in this database, 6% of drugs, we have enough power to say something clinically meaningful about the effect. An MDRR greater than 10 is likely not very informative. You can probably produce an estimate, but the confidence interval is going to be so wide that from 0.5 to 10 or something, that's not going to help you in any way. And we see that in this database, 83% of drugs fall in this category. So this is assuming the outcome is rare. We can also do this assuming the outcome is uncommon, so 1 in 100, or very rare, 1 in 1,000. And we've done this across all the databases in the network, and of course, combining them all. This table is a little bit hard to read, so I just here picked the smallest and the largest database and then the entire network. And just highlighting some numbers here. Here we see that most databases cannot study most drugs on their own, even when the outcome is what I would say pretty relevant, 1 in 100. We see that even the largest database, the majority of drugs fall in this class where we do not have enough power to study them. And the smallest database, almost all of the drugs do. In contrast, if we combine across the OHDSI network, well, then of course we have much more power, and there's only 9% of drugs that we think we won't have enough power. 73% of drugs we will have enough power to study them. And in fact, if you look at like the distribution within this quadrant, you see that it's shifted to the left, meaning there are actually many drugs for which we have a lot of power to study them. What I also find interesting is that if we go to the right, where when we assume the outcome is very rare, which many of the outcomes that we study are, then even the OHDSI network doesn't really have enough power. 47% of drugs we don't have enough power at all, and only 29% of drugs do we have enough power to actually say something meaningful, probably clinically relevant. So I think this is a call to say that we need a bigger network. We need more people to join the OHDSI evidence network so that we can study more drugs. And everybody should go talk to Claire and sign up to join the network. So I've mostly now been, or exclusively been talking about the precision around the meta-analytic estimate, actually, around mu, a defect estimate. But there is another type of precision, tau, which also actually matters. So, because we want to measure heterogeneity with sufficient precision. The uncertainty around mu, so our effect estimate, is mostly determined by the number of people in the total network, where the uncertainty around tau is mostly driven by the number of databases. So if you want accuracy around tau, you will need more databases. To make this, again, use this more cartoon explanation, in this case, we had 4 averages as our population. And from this, we computed the mu and we estimated the mu and tau parameters. Well, 4 is not a very big sample. And in fact, we don't really have 4 because each of these comes with its own uncertainty, so we have less than 4 in this sample. And so we need more to accurately estimate tau. So that's why we also recommend that if you're going to report tau, you should also report the uncertainty around it. And so here I'm doing that by showing the credible interval around both mu, which is our main effect estimate, and tau. But that's probably a little bit hard to process, because now I have 2 numbers, both with a credible interval, and I'm not sure what to do with those 2 things. And so one solution to that is called the prediction interval. The prediction interval integrates mu and tau and their uncertainty. And the term prediction interval, this is directly from the Cochrane Handbook, relates to the use of this interval to predict the possible underlying effect in a new study. So based on the data that you have, you're trying to now predict what would the next study find. But it has to be a study that's similar to the studies that's already included in the meta-analysis. Simplistically, if you wanted to compute it, the prediction interval is centered on mu and has a standard deviation that's roughly a combination of tau and the standard error of mu. But the way that we compute it in a Bayesian way, it includes both the uncertainty around mu and the uncertainty around tau. So the more databases you have, the more precision you have around tau, and the narrower your prediction interval probably will be. So just to show you an example of this prediction interval and how it works, here's an example from the poll that you saw earlier and judged. In this case, there's a lot of consistency between databases. We only have 4, but that's enough to estimate the tau with fair amount of accuracy at 0.12. And as a consequence, the prediction interval shown at the bottom is actually pretty narrow. And what I think is neat about displaying it this way is, if we interpret what we're seeing here, is that both the prediction interval and the meta-analysis estimate agree that there is an effect. Which means that not only did we observe it in the databases that we included here in the study, but we also predict that the next study will show an effect within this prediction interval and therefore show that there is an effect. So in a sense, we're much more certain now that we have this prediction interval than we were before that this is something that we will be able to replicate. And I think in times of, when we're talking about like the reproducibility crisis, I think this is an important feature to have. Here's another example, also from the poll earlier, where there is lots of inconsistency between the databases, and we estimate tau to be large. And as a consequence, the prediction interval is very wide. And so in this case, even though the meta-analysis itself shows a significant increased risk, the prediction interval is very wide, saying that the next study that might be published may very well show, for example, even an effect that is significantly decreasing. And this actually makes sense already if here you see that we already had a database in our study that actually showed a protective effect. So I think the value of the prediction interval is that when we have a tight prediction interval, we expect that any conclusion that we draw from the prediction interval would not be changed by the next study. In other words, we expect high replicability. We sort of joke that if you have a very tight prediction interval, then you can finally say no further research needed, because usually it's always more research needed. And in this case, you're kind of saying, I will expect that the next study will show the same effect, so no further research needed. It's a bit tongue-in-cheek, because I also agree with George that you want different perspectives, so it's not just the OHDSI perspective that should weigh in on something. But I definitely think there is value to this high replicability value proposition of the prediction interval. If the prediction interval is wide, well, we may have learned something, but we then are very unsure whether our results can be replicated. So like the first one gets a gold star, and I guess the second one doesn't. If you're looking to get tight prediction intervals, which is, we say has high value, then, well, the requirements are you need high precision around mu, which means you need many patients in your study. You need to have high precision around tau, which means you have to have many databases, and low tau, which is the consistency, which is not something you really can control, but at least if you follow the OHDSI best practices, it seems that that tends to be low. Here's another more technical finding that I did want to mention, is that if there is inconsistency that mostly stems from residual systematic error, like we saw in the legend studies, then the prediction interval itself in simulation, we could show that that actually has better coverage of the truth. So it's in a sense a better calibrated interval. But I will leave it at that and not bore you with the simulations that we did. What I do recommend is, just in general, that we should start reporting these prediction intervals in addition to what we've already been reporting. So moving on to the last cell, accuracy across databases. As I mentioned, we've already done a lot in OHDSI to reduce bias within each database using advanced methods to control for confounding, objective diagnostics, and calibration. We also mentioned that when estimates are consistent across databases, then we feel assured because then it's unlikely that there are any database-specific residual biases. But we need to make a little of a qualification to that. Because if the databases are very similar, then I'm not sure how much more reassured we are by seeing consistency. So the intuition here is that if we observe consistency across US claims databases, that is less informative than we observe consistency across claims EHRs in different countries. And that was actually one of the polls that Patrick showed you, where the majority of you shared this intuition that if you see consistency across more different databases, then you feel more reassured. And so if you look at the OHDSI evidence network, well, there's lots of diversity here. Here we color-coded all the different countries, the data types, the care levels. So if we were to observe consistency across the OHDSI network, we probably would be more assured than if we just observe it across, for example, US claims. So this is a manual classification of the OHDSI network. Of course, we like to quantify things. So let's introduce a measure of diversity in the OHDSI evidence network. I don't think this is the final answer, but just bear with me. This is what we did now. We computed similarity, just cosine similarity for these databases based on aggregate statistics. So one similarity was for demographics, one for longitudinality, so how long were the observation periods in these databases, visit composition, inpatient, outpatient, emergency room, and condition and drug prevalence as a sort of a proxy of the healthcare system. And so for each, we computed the similarity, and we just averaged across those similarities to give each a similar weight. The nice thing about this metric is you can compute it directly from the aggregate data already collected for the database diagnostics, which was collected in the OHDSI evidence network. And so we tried this out, and we computed similarity for all databases in the OHDSI evidence network. And so here I'm showing you those similarities. So both the x and the y-axis are databases, and the color coding in each cell indicates how similar they were. So the light color indicates low similarity, and the dark color indicates high similarity. I also did a hierarchical clustering, as you can see, so that you can actually see that there are many databases that form clusters here. And as you probably would expect, like there's a very strong cluster of US claims databases which are highly similar. There's a very strong cluster of non-US databases and a cluster of EHR databases. Which is just to say we do see a lot of diversity in the OHDSI evidence network, which I think is very, very good to see. But as I mentioned, we had a claim that we feel more confident observing consistency when there's high diversity. That sort of makes an assumption that we would like to test, because it assumes that if databases are more similar, that they will have similar biases, and if they are more diverse, that they will have more diverse biases. So I felt we had to prove that point. So does this similarity that we see here correspond to similar biases? Well, how do we compute that? So let's go back to the Legend results. In this case, we'll look at Legend diabetes, where we also did an analysis where we did not adjust for anything, so no propensity score adjustment. And the reason why we're focusing on those is because those will be biased, so we can use it to measure bias. Problem with our methods is that they're basically so good that we have very little biases left after we do the full adjustment. So we're focusing on unadjusted estimates. Here on the x-axis, I'm showing you the hazard ratio in the CCAE database, and on the y-axis, the estimate in the Medicare database. Both of these are US claims databases. And so for a single target comparator outcome combination, in this case, DPP-4s, compared to sulfonylureas for the outcome of ingrowing nails, we see that both CCE and Medicare have an estimate, an unadjusted estimate that is basically 1, hazard ratio 1, which is good because that's what we believe to be the truth, but wasn't necessarily what we're going to find because it's unadjusted, so there could be bias. But in this case, we both agree on the effect estimates and both agree on basically 0 bias. But that's not always the case, because with unadjusted analysis, anything can happen. In this case, we see that both CCAE and Medicare estimate the hazard ratio to be 2 for when comparing GLP-1s to sulfonylureas for the outcome of melena, which is actually another negative control. So the true effect is 1, but both estimated to be 2 or greater, and that is because of bias, but it's a bias that they share, so they are in agreement there. Here's another example where they don't agree. So this is GLP-1s versus GLT-2 inhibitors for the outcome of a nicotine dependence, another negative control. Now CCAE thinks the hazard ratio is low, while Medicare thinks it's high. So they're both biased, although Medicare is more biased, but they're biased in different directions. And so by comparing these estimates, we can now basically compare biases, and we can do this for all of the target compared outcomes that were included in the study, and we can look at the correlation. But to do that, we do need to make sure that we account for the fact that some of these estimates are very uncertain and some are more certain. So in the picture here, I'm trying to display that by using these very faint large circles for any estimate that has a standard error greater than 0.4, and the small dots for the ones that are more precise. We also just computed correlation with a measure that actually directly takes into account the standard error. And so here, if we compute that correlation, we see a correlation of 0.91, a Pearson correlation. That's very high. But that's also between two US claims databases. Now let's compare CCE to Optum EHR. So both are US databases, but now one is claims and one is EHR. And you see that there is still a high correlation. Both are US databases, but the correlation has now dropped to 0.83. And if we compare CCE to the IQVIA Disease Analyzer Germany, which is a German EHR system, I think we still see a fairly high correlation, 0.71, but it's lower than the other two. So we could put all of these correlations into a big correlation matrix shown here. So X and Y axis are both databases in the Legend diabetes study. And the color indicates how correlated they are in terms of their biases, with the dark red being more correlated and the light yellow being less correlated. And of course, the interesting question is, well, how does this relate to the similarities that we computed earlier? So I'm now showing those same similarities on the left-hand side just for the subset of databases that were included in Legend Diabetes. So again, to orient you, left-hand side is similarities based on database characteristics. Right-hand side is basically similarity in terms of the biases that we see in these databases. And probably already by just eyeballing, you can see that there is agreement between these two plots, left and right. I also just computed a Pearson correlation, which I admit is probably a little bit hard to follow, that you have a correlation of two correlations. But still, we did it. Correlation of 0.46, which is not as high as I thought, but there is one database, sort of an outlier, which is something interesting to look at. But still, there is a correlation, a very clear correlation between the two. So in other words, a long way around to say more different databases will have more different biases, and therefore if we still observe them to be consistent, then we feel better about our estimates. Another question that we can ask is, well, how diverse was Legend Diabetes? So let's just put these two side by side. So on the left-hand side is the entire OHDSI evidence network, and on the right-hand side is Legend Diabetes. We do see a suspicious cluster in the middle here of Legend Diabetes that probably corresponds to the US claims databases, and in fact it does. We can look at it in the previous slides. And that's the majority basically of these databases in Legend, and there is more diversity in the entire network, but I'm still proud of Legend Diabetes and the diversity that we achieved there. But I think it could be improved. So I think moving forward, this is something that we could do in all of our studies, take into account the diversity of our network and make sure that it is high. All right, one final thing I want to say about accuracy, about network studies versus single studies, is sort of related to what Patrick was saying about the order in which things are observed. So here, just a specific example from a Legend study where Optum EHR finds a large increased risk. But then if we look at the next database, we see that, well, maybe we shouldn't have been so sure that there was an effect. And if we look at the entire evidence from the network, we are actually not sure at all that there is an effect. And the reason why I find that these patterns concerning is, well, what happens when you think of that as how that will play out in the literature is each one of those had been done as a single study. So we have all our studies, we get the results, some of them are significant. The ones that are not significant, I mean, you had a hypothesis, you tested it, and it proved not to be true. Usually those studies end up in the file drawer, and only the ones that are significant then are submitted for publication, and then there's a further selection process. So probably the only ones of those single database studies that will end up in literature are the ones that are significant. And now if you do a meta-analysis of that, you basically cherry-picked the ones that were significant and you ignored all the ones that had no findings. I found this interesting paper by Yang et al., which is from a different field, but their estimate was that 66% of significant meta-analysis would become non-significant if you adjust for publication bias. So in other words, By publishing these studies one at a time, you are introducing a bias, or you're becoming less accurate. Where in contrast, the power of a network study is that you basically move the meta-analysis forward. There is no selection on which one is significant or not. So you have an unbiased sample of the databases, and therefore you would have a more accurate results from your study. So just to see how often this plays out, again, let's go back to the Legend Diabetes study. And if we look at just the 191 target comparator outcomes where we have at least 2 databases passing diagnostics. Here we see that for 29, almost 30% of these TCOs, none of the databases produce a significant effect. For 66% of these, at least one database shows a significant effect. So that's a very large proportion. And actually there's a 4.2% where 2 databases are significant in opposite directions. If we now look at the next level, meta-analysis, we see that of those 66 where at least one database was significant, half of them, if you look at the meta-analysis, they no longer are significant. So had just that one database study been published, we would have probably been misled. Finally, we are now arguing you probably want to produce the prediction interval. So let's see what happens here. And there we see that of the 33% where the meta-analysis was significant, 9.4% actually also the prediction interval agreed that there was an effect. And just to remind everybody, these target comparator outcomes, they're not selected to be positive. They are just questions that we had. And the fact that we find 9% where we are pretty sure that that there is an effect that we could replicate is actually pretty substantial. We go to legend hypertension, we have more TCOs. We have also probably less power, so we have a larger proportion where none of the databases are significant, and about half of them we do find at least one database to be significant, but still here an even larger proportion of those, the meta-analysis and of course the prediction interval show there is no effect. In this case we had 2.5% where we also, the prediction interval agrees that there is an effect. All right, let me wrap up my story. So in summary, network studies add value to our evidence in 3 dimensions. Consistency, we can qualify consistency by using tau, which comprises effect heterogeneity and differential systematic error. And because it includes both, then probably we prefer estimates that are consistent, so have a low tau. Precision, to increase precision around both mu and tau, we need more patients and more databases. And we can nicely summarize mu and tau in the prediction interval. In terms of accuracy, we've argued that observing consistency in a more diverse data network strengthens our belief that the result is accurate, and so we are advocating for more diversity in our data. And often, a single database will agree with the meta-analysis, so we should focus on the meta-analysis. And there's another reason why we would prefer network studies and not single database studies. All right, with that, I want to hand it over to Asieh.
Thanks, Martijn. Hi, everyone. We're ready to talk a little bit about cancer. So, as some of you know, I'm very passionate about oncology, and today I want to just use the next 9 minutes and 46 seconds that I have to talk a little bit about our path towards generating reliable evidence in cancer. And for that, I'm going to focus on metastatic bladder cancer. So, how do we treat metastatic bladder cancer? Not going to go into the clinical details, but just to bring everyone on the same page. When we talk about metastatic bladder cancer, we're referring to stage 4 disease, which is a cancer that has spread beyond the organ, spread to other organs. And usually the treatments or decisions on how to treat come from clinical guidelines. One example, there are many clinical guidelines in oncology that we're going to focus on today is the European Association of Urology guideline for metastatic bladder cancer. Let's take a look. So this is the 2023 edition or version of the guideline, which says that if a patient has metastatic bladder cancer, there are basically 3 different treatment options, either a cisplatin-containing regimen, if the patient is eligible, meaning that the kidney is working properly, or they can get carboplatin-containing regimens. If not, they can receive PD-L1 if they're eligible, and if not, they should just receive best supportive care. The evidence that support these decision-making comes from usually randomized clinical trials, and this is where the evidence is coming from. No need to go through that, but the majority of evidence are coming from publications and clinical trials from 2 to 3 decades ago. That has been the case for almost 22 decades, or 20 years. Up until around 2 years ago, where the result of a pivotal study was presented at ESMO around the same time, looking at a combination of enfortumab plus pembrolizumab for the treatment of untreated advanced, or basically locally advanced and metastatic urothelial carcinoma. And as you can see on the left side, the combination showed superior efficacy, both in terms of overall survival and progression-free survival compared to chemotherapy, cisplatin, or carboplatin-containing agents. That immediately resulted in an approval later in 2023 in the US and last year in Europe and elsewhere. And the guideline, the 2023 guideline turned into this. There is a new decision and treatment recommendation. There is a new arm which recommends enfortumab plus pembro as a preferred treatment option, assuming that patients are eligible for the combination. That's pretty good, but there is a but in that. The guideline explicitly says that the current eligibility criteria is coming from the pivotal trial of EV-302, and these eligibility criteria is likely to undergo changes when we know more about the patients that are treated in the real world. The guideline is specifically asking for more evidence. Talking to clinicians and experts in the field, we've talked to GU oncologists and also the guideline group. There is a call for more evidence. They talk about the timely need for more evidence to know which patient should receive the treatment, who will benefit, how should patients be treated after they progress on the combination. Looks like that there is a call for us. We can do something. We can actually help answer this question together. So going back to the trial, if you think about it, so the EV-302 trial looked at 420 patients who received enfortumab plus pembro in the treatment arm. We should be able to do that in the network or across in any of the databases. Let's take a look. We went to one of our databases, a cancer center, a typical cancer center with all cancer patients. All we saw was around 20 patients who were receiving enfortumab. So what you see here is a bar chart. So the cancer site is just a tertiary EHR. In the US, 20 patients. We have a lot of other data partners. So across all of the cancer, all the centers that were able to look at it, and these are 22 sites, we see a little bit more, sometimes less, and sometimes no patients, right? But in none of the 22 databases, we have the sample size that we see in the clinical trials, 420. This is right now at a very, very critical stage because the drug is approved and it's reimbursed in some countries, and it's not, the need for evidence is quite critical to actually also help with decision-making of how to use it and on what patients. But looking at the whole thing, none of our centers are able to answer these questions alone. There was a little bit of an oh-no moment for me. What should we do? And then I realized that this is oncology. This is just an example, one example of why cancer is a rare condition, why we need to come together. So bladder cancer is the 9th most common cancer Around 600 new cases of bladder cancer are diagnosed yearly. Not every patient gets metastatic, around 5%. Less than half, 40%, get treated. And then these 2.4% of the total population that become metastatic and get treatment will divide into those little pieces of pie of different treatment. This is basically what the literature says and what we know about how patients are being treated. So think about it. From the 600,000 bladder cancer, less than 1% is potentially eligible for our combination drug, M412 plus Pembro. That's less than 6,000 patients globally every year. Take that little piece of pie to your database. That means a very, very small number. It is a rare condition problem. And what we can do is to look into a network. That's why we're here. So what if we create a network based on all the 22 data partners together? Together, we have 578 patients where we can study to see what happens, who are these patients, how they're being treated, how do they respond, and what they can receive after. If we look across the network and the other treatment recommendation groups, we see again, looking at a cancer center, we have very, very small numbers for any of the other treatment, although they've been there forever, more than 2 decades. This is comparing with the red numbers on the plot, which is the total number of patients that have been participating in the pivotal trials and that have been contributing to the evidence generated and the evidence that was used by the guideline. So 72 versus 1476 for cisplatin-containing regimen, and then it goes on. If we look across the network, each centers, we see the same pattern. None of the centers by themselves, for example, in the cisplatin-containing regimens, have enough sample size, as many as what we can see in the pivotal trial, to contribute to the evidence alone. And looking across the plots, you see that no single database is necessarily better than the other in being able to generate evidence. But together, if we combine the forces together, we can see that at the bottom, we have more than enough patients to start asking questions, start looking into what works and what not, and generating evidence. This is only possible if we come together and we create a network, and we start asking questions, systematic questions in oncology. That's only, and this is the work that has been done through a network and a group of amazing individuals, most of them who are sitting here, that's made it possible. We call it Falcon Bladder Network. There's more than 24 data partners, a lot more than what you see here on the screen in terms of the countries and data partners. Those are the ones that I had permission to put their names on. These individuals have put their time together to go through the data, improve their data quality, and work as a network. So for me to come here and present it, none of us can do it together. It's just the power of us together to make it possible. So with the 14 seconds that I have, I really want to ask every one of you, if you're not here, there's still time, come join us and let's make something very impactful on bladder cancer. Thank you so much, and I give it to Cindy.
Right. Thanks to the organizers for the opportunity. I'm really excited to share our work with everyone, which kind of applies many of the concepts that Patrick and Martijn brought up to a real clinical problem that we were having the summer of last year. So as many of you know, semaglutide is a GLP-1 receptor agonist with many proven cardiovascular and kidney benefits. And it's one of the preferred treatments recommended by the American Diabetes Association for the treatment of type 2 diabetes with all these other risk factors. And last summer, it was linked to an eye disease called non-arteritic anterior ischemic optic neuropathy, or NAION, which is basically a stroke of the optic nerve that leaves about a quarter of eyes with vision that's considered legal blindness, for which we have no definitive treatments. And the paper that made this connection was published in JAMA Ophthalmology by Hathaway and colleagues from Mass Eye and Ear, which is the ophthalmology department at Harvard, in which they found over 8.9% of patients on semaglutide were developing NAION, or 6.5% over a year. And if you look at the European Medicines Association categorization of side effect frequencies, this is considered a common side effect. And more importantly, they were showing that patients with type 2 diabetes who were on semaglutide had over a 4-fold increase for NAION compared to comparable patients who were on a non-GLP-1 receptor agonist. But of course, there were many limitations to this study, the primary one being it was at a single academic center, which was a major referral center for cases of NAION. And the authors acknowledged their limitations. They said, really, there needs to be a much larger, retrospective, multi-center, population-based cohort study to confirm, refute, or refine their findings. But the lay press took the findings from the paper and kind of went wild. This is just a screenshot of a few of the papers that came out around this time, including this one from CNN that warned people about the use of this diabetes drug with blindness. And all of our ophthalmology clinics were fielding panicked phone calls from patients asking us if they should be stopping their semaglutide. It got to the point where our governing bodies, the American Academy of Ophthalmology, AAO, and the North American Neuro-Ophthalmology Society, or NANOS, had to issue a public press release reminding everyone there were limitations of the study, and at this time, we are not recommending that patients stop taking their semaglutide. And the OHDSI community was well poised to address the limitations of the Hathaway study. This question of whether or not semaglutide confers a higher risk of NAION compared to other medications falls under one of the standard OHDSI questions for population-level effect estimation. And so we have since published our study also in JAMA Ophthalmology. And there were many strengths to our study. We were able to look at multiple databases because we're part of a network. We evaluated multiple outcomes, and you'll see why that's important in a moment. And we also evaluated multiple study designs, as Martijn alluded to earlier. And so we identified patients with type 2 diabetes using the same definition that was used in the Legend type 2 diabetes study that we heard a lot about at last year's Global OHDSI Symposium. We found patients who were exposed to semaglutide, dulaglutide, and exenatide, which are the GLP-1 receptor agonists. Of course, our study was focused on semaglutide. And we also included patients who were taking empagliflozin, sitagliptin, and glipizide, which represented non-GLP-1 receptor agonists. There is no structured diagnosis code for NAION, and other studies have found that the more generic ischemic optic neuropathy code, about 40% of those cases are not actually NAION. So we constructed two slightly different variations of our outcome phenotype, one that we knew was going to be more sensitive and picked up more cases, and one that was more specific by requiring 2 ischemic optic neuropathy condition occurrences. So we had 2 study designs, an active comparator new user cohort analysis, as well as a self-controlled case series analysis. And in the active comparator new user cohort analysis, we identified new users of semaglutide who were on semaglutide for treatment of their type 2 diabetes after metformin use, and we compared them to propensity score matched new users of dulaglutide and exenatide, the other GLP-1 receptor agonist, as well as the other medications. And we used large-scale propensity score method and Cox proportional hazards models to generate the hazard ratio estimation. And in our self-control case series, we identified all patients who had NAION and individuals served as their own control and estimated the incidence rate ratio for NAION during semaglutide exposure compared to non-exposure time. And we did this similarly for all the other medications that I mentioned and used conditional Poisson regression models to generate the incidence rate ratio. And for both study designs, as with all other OHDSI network studies, we employed a comprehensive set of study diagnostics, including the use of negative controls, and only databases that passed all study diagnostics were included in the Bayesian random effects meta-analysis that summarized the effect estimation across the entire network. So we included 14 databases across the OHDSI evidence network, and you can see here there were 6 administrative claims databases ranging from commercial databases to all the way to Medicaid, and 8 electronic health records ranging from single academic institutions like Hopkins or Columbia to aggregated EHRs like Optum and to integrated centers like the VA. We identified over 800,000 new users of semaglutide who are on that for the treatment of their type 2 diabetes, and found that the incidence rate of NAION among this cohort was anywhere between 8.7 to 14.5 per 100,000 person years, which is orders of magnitude lower than the estimates that Hathaway had published. And not surprisingly, we were picking up more cases with the sensitive NAION definition as compared to the specific across all the groups. This is a forest plot from our active comparator new user cohort analysis, but to show the results in a graph similar to what Patrick and Martijn had been showing, when comparing patients who are on semaglutide to dulaglutide, looking at the sensitive NAION definition, we really are not seeing a difference in the risk of NAION, as you can see from this mu, this represented by this diamond here. And so similarly, no difference when looking at this drug comparison for the specific NAION definition or when comparing patients who are on semaglutide to sitagliptin or semaglutide to glipizide across either definition. But when you look at semaglutide versus patients who were on empagliflozin, again, no difference using the sensitive NAION definition. But when zooming in on the specific NAION definition, you can see that there does appear to be a slightly higher risk of NAION among the semaglutide patients. But the tau represented right here is quite high at 0.29. And when you calculate the prediction interval that Martijn introduced earlier that considers both the mu and the tau, you can see that this now crosses the hazard ratio of 1, so we're even less confident that semaglutide necessarily confers a higher risk of NAION when compared to empagliflozin. And this is the forest plot from the self-control case series that we published. And the big thing to note from this graph here is that when we applied this self-control case series analysis for the other GLP-1 receptor agonists, as well as each of the non-GLP-1 receptor agonists, we weren't really seeing a difference in the risk of NAION, either across the sensitive or the specific definition. But the semaglutide told us a different story. And so zooming in, so we found a higher risk of NAION associated with semaglutide exposure compared to non-exposure that was consistent for both the sensitive as well as the specific definition of NAION. And just zooming in on the sensitive NAION definition, we see an increased risk of about 1.32. And notice the tau here of 0.07, reflecting heterogeneity across the databases, is quite low. And when you recalculate the prediction interval, it still suggests that even if we conducted the study and added another database, we'll still see this increased risk for NAION, as I will show later. And so after we conducted our study, we concluded that there does appear to be an increased risk of NAION among patients with type 2 diabetes exposed to semaglutide, but this increased risk is much smaller than what was previously reported by the Hathaway paper. And furthermore, the incidence rate of NAION is also much smaller than previously reported, on the order of 100,000 person years as opposed to 100 person years. And so of course, there were many strengths to our study. We were able to include multiple databases simultaneously, evaluate multiple outcomes and multiple study designs that really improves the generalizability, the replicability, and the robustness of our findings. And other authors recognized the strengths of our study as well. When our paper was published, it was accompanied by an editorial written by the original authors from the Hathaway paper, in which they congratulated us on conducting a thoughtful and well-designed study that really advances our knowledge about the topic. Since our paper was published, there has been an explosion of observational studies in the literature on this topic. And as you can imagine, because these individual studies were not done as part of a network study, they were all slightly different targets, slightly different comparators, and of course, slightly different conclusions, some saying there is no increase in risk, some saying that there is an increase in risk. And when you conduct a meta-analysis across all the literature, selecting the studies that were cohort analysis, you can see there appears to be a slightly increased risk of NaION among semaglutide users compared to other medications, but the tau here, reflective of the heterogeneity across all of these studies, is incredibly high at 0.49. And when you recalculate the prediction interval, again, it crosses 1, suggesting that even with all of this evidence out there, we're still not confident that semaglutide necessarily confers a higher NaION risk compared to another medication. But again, the self-control case series story is a little bit different. Even when you add data from Denmark and Norway, places outside the US, you can see this increased risk for NaION associated with semaglutide exposure, and the tau continues to be quite low. And when you recalculate the prediction interval, it still suggests a higher risk for NaION associated with semaglutide use. So our study, as well as all the other observational studies, led the EMA Safety Committee to conclude that there does appear to be an increased risk for NaION associated with semaglutide. So they recommended that all medications that contain semaglutide get updated to include NaION as a side effect, but with a frequency of very rare, which they define as up to 1 in 10,000 person years, which is exactly the estimate that we had produced. And keeping in mind all these different EMA side effect frequency categories, there is no category more rare than very rare. So clinically, our governing body stepped in and helped everyone interpret these findings. Given that NaION is very rare and that the risk is pretty small, both the AAO and NANOS are not currently supporting a blanket recommendation for all patients to immediately stop taking semaglutide if they develop NaION. But of course, as we know, patients are not necessarily making all of their medical decisions based on numbers alone, and this really has to be an individualized decision in which clinicians help our patients interpret this data in the context of the patient values, risk tolerance, and others. So I just want to conclude by saying I'm so proud to be part of this amazing community, this amazing network of folks who was able to come together really quickly last summer and answer this really important clinical question that came up. Thank you so much.
So I'm going to conclude this plenary just with some summaries of what you heard. So you heard from Martijn about why network studies are necessary to improve trust in terms of the methodologic issues and the desire for us to try to aspire to have precision and accuracy and consistency. You heard from Asieh an example of why we need to have a network, because precision is the only way we're actually going to get the sample to study oncology questions like bladder cancer. And you saw from Cindy an example where consistency and accuracy actually can completely shift the game. When we talk about network studies, though, the challenge that Cindy also highlighted in the semaglutide NaION also gets back to George's opening when we talk about trust. Because now we're not just talking about evidence and statistics, we're talking about debates about what to do. And when individual studies get published, those debates start in the absence of the rest of the evidence. So I'm going to make a brief pitch, and then I think we will have a couple minutes for questions. If anybody's interested, we have a couple mics in the middle of the room, so if you have a question for anybody, please come up. First thing that I'm going to highlight is, why is a network study better than a single database study? So maybe we've convinced some of you like a network study is a good thing to do, but it's hard and it's like a lot of work and you got to collaborate, and it's just a lot harder than if you just have access to your one database and go do your one study. The argument that I'm going to make is on these dimensions of accuracy, precision, and consistency. So let's first start with accuracy. You heard that diversity is necessary for us to assess accuracy. You are not a diverse data network if you have one database in your data network. So you will always be worse on the dimension of accuracy if you do a single database study. If we talk about precision, you heard from Martijn that there are two dimensions of precision: the number of patients and the number of databases. You will always be worse on the dimension of precision if you do a single database study. Not only that, you will have your one database that can only contribute what random error that it has, but you don't actually have the ability to understand that a cross-source random error that you can get from a network study. And then consistency, hopefully we've convinced you like consistency is an important attribute. And the challenge that we have is if you have a single database study, you can't even estimate consistency because you're consistent with what? You've just published your one answer and then you're going to start the debate in the absence of science. So I'm going to make a strong assertion. Many of you have access to data. Many of you are publishing studies. Many of you aspire to publish studies. And I don't want to say you can't publish your single database study, because George won't let me. But I will say, if you want to answer a question and you want that evidence to be reliable, and you can understand why reliability requires accuracy, precision, and consistency, if you've already designed your study to run in your one database, why not create a network study and run that analysis across the network? This is an opportunity we have as a community because of the fact that we have standardized our data, we have standardized tools, we can generate evidence at scale, and it can actually be more reliable. But that depends on all of you to make sure that you're upholding this higher level of standard and getting away from the single database study that could potentially cause harm and get towards that higher end of that evidence hierarchy when we can think about when we're producing evidence that's reliable. Now, as it relates to that, we're not at the top of the evidence hierarchy. Meta-analyses still are, and we're still languishing in this observational world somewhere in the middle. And there's reasons why meta-analyses of published literature may actually be better than our network studies. If we think about accuracy, well, a large part of meta-analysis is actually synthesizing evidence from randomized clinical trials. And we know that randomized clinical trials are less subject to bias than our observational studies, even if we do all the fancy things that Martijn talked about. So indeed, I'd say like a meta-analysis of randomized trials, if there were enough randomized trials out there, I may trust that more than our observational network study. Absolutely. If we talk about precision, there's also this idea that even if we do a network study together, we're ultimately still producing one study estimate. And a systematic review has the advantage of saying, let's get all the evidence from all the papers and bring it together. So a meta-analysis of literature has some value there. And one of the interesting things about a meta-analysis of published literature is that because independent research groups independently did studies and they made those slightly different study variants, well, that's a double-edged sword. On the one side, you could actually say, well, the fact that everybody independently did different things, if you observe consistent estimates, that actually strengthens your argument. As opposed to in OHDSI, if we were to have like groupthink and all just agree to one study design, well, maybe that wouldn't reflect the full consistency you would want. So there's lots of reasons why a meta-analysis of published literature could be better than our network studies. But I also want you to think about why our network studies may be even better than meta-analysis of published literature. So as we've highlighted here, if we think about consistency, that double-edged sword that I just mentioned, while it would be nice if different studies with different designs gave consistent answers, when you see differences, such as what Cindy presented from the semaglutide thing, what you resulted is when you see differences, you don't know where the source of the difference is. Our meta-analyses actually allow for us to conduct systematic analysis across all of our databases, which has value. From a precision perspective, a meta-analysis of the published literature is just limited to whatever's in the published literature. As Martijn highlighted, we actually have the opportunity as a network to think about prospectively planning how to do retrospective analysis of our data network. You can figure out how many databases you actually need and make sure that you have the power that you want to answer your question. And then the last argument that I would make is that as anybody else reads the Cochrane Handbook for pleasure reading at night, just like I do, you will read that they've got entire chapters talking about the concern of non-reporting bias. What other people talk about is selective publication bias. And the challenge there is that ultimately if the null estimates aren't in the literature and are not accessible, it means that your estimate from the published literature is fundamentally biased. By moving the meta-analysis early and making sure we use all database estimates, we actually remove the bias that is really, really a challenge for all typical meta-analyses. So I'm not saying that we all as OHDSI deserve to be at the top of the evidence hierarchy, but I will assert that if we can actually follow these standardized practices, we can be a lot closer to reliable evidence than what we can do individually and alone. So I will just end with specific guidance and recommendations for you all about network studies on these dimensions of accuracy, precision, and consistency. First, I want to encourage all of you to think about your next time that you want to answer a clinical question to run a network study. You should do that by designing and pre-specifying your study to consider accuracy, precision, and consistency along the way. You should be applying objective diagnostics with pre-specified unblinding decision criteria to make sure that any estimates you produce are legitimate. And you should make sure that that network that you recruit is diverse to represent the populations of interest. You should design your study to ensure that it has adequate statistical power, not just on how many patients, but also on how many databases. And your one database study is always the worst as it relates to power of number of databases. Luckily, Martijn showed you that we can calculate the minimum detectable relative risk for that prediction interval, which actually means that you can actually figure out what you need to design a study. And up front, you should be thinking about what are those multiple analytic design variants that you're going to want to run, what pre-specified subgroups you're going to use to explore heterogeneity treatment effect. All of these are things that you have control as a researcher before we ever touch the data. But once we execute that analysis, once we produce our R package out on our GitHub OHDSI studies, once we have our package that is executed across the network, once aggregated summary statistics come in, it's our obligation to be transparent in the reporting and interpretation of those results. That means we have to share all of our diagnostic results, whether a database passes or fails. We should summarize the network diversity, not just in terms of the aspiration of who was coming into the network, but also who remained after we've applied these blinding criteria. We need to report estimates from all of the sources that contribute. We have been doing meta-analysis, but we're now arguing, based on what we've learned, that we think it's really valuable for you to actually look at not just mu and tau, but their respective uncertainties, and it would be helpful to use a prediction interval as a composite summary statistic that helps you understand how reliable your evidence really is. And as it relates to consistency, when we usually write our observational studies and we always put that hand-wavy sentence of more research is needed, I'm going to suggest that we can actually be a lot more directive about what that research is. Because if you do a study and you have low tau, but you don't have enough precision to answer your question, you know exactly what that more research is. You've got to go do more replications, because more replications will increase your precision and you'll actually get to a responsible answer. However, if you've learned that your tau is high, that you observe inconsistency, doing more replications doesn't actually help. It just adds to the noise, just like Cindy showed. Instead, you need to start thinking, what are the new hypotheses that we can test to explain that heterogeneity that we observed? I think that these are very tractable things that we should be doing as a recommended best practice, and that we should be encouraging all of our colleagues as we're thinking about using our collective skills together to generate reliable evidence. But it does start with the fact that we all need to hold hands and recognize that we are a data network together. We are not a series of individuals who each have a series of individual databases that are running individual studies and that just happen to come together in New Brunswick to share what we learn. But instead, we're one community together. I hope all of you who are data partners will hear this and join our OHDSI Evidence Network as a mechanism for us to actually collaborate and make what could be transformative change in how evidence from observational studies is received and used and is credible for helping support clinical decision making. So with that, we're going to stop. We've got like 5 minutes. If anybody has any questions or comments for any of us, please come up to the mics, and Martijn and Asieh and Cindy will be happy to answer your questions. And I see Wojciech's already run to the mic. Well done, Wojciech.
Hello, great talk. It's nice to have these motivational examples. I have a comment to Martijn and then one question to Cindy, or actually Martijn and possibly Asieh as well. I would argue that we actually have 3 networks, maybe possibly even more, if we count Darwin and Eden as 2 networks. We might have the Falcon network, we might have the evidence network, and again, Darwin/Eden. What we saw was basically these networks have something in common. They collect aggregate data, and then they can say, count for bladder cancer, we would have this much patients. Or you presented a very nice result, one on the causing similarity of databases, but more importantly, on the where do we have the minimum detectable risk under, or like over 4, so no hope in the network. These, I would classify any research And I would argue that's informatics methodological research rather than let's do more studies. I would classify these studies on the network as either requiring additional collection or relying on the previously collected data under the previous protocol. So my comment is more, it would be nice to see more of those studies. I see that researchers, mostly from Columbia, close to the coordinating center, often come up with those things. So I would like to learn, for example, from your protocol, which explicitly states, hey, I don't need additional data collection, so I don't need to go all individual network partners and ask them for permission to run the study. So that's a very important enabling factor in all these research. And so that's the comment. Like, I would love to basically take your protocol for causing similarity, copy it completely, and run my laboratory results unit study, and not having thousands of questions. Hey, give us a protocol. I will just say, well, my study is the type of protocol which requires no additional data input from sites. And hence, I would argue, so actually that's a question. Did you go to all individual sites, let's say IQVIA? Can I run your study which looks at MDRR or tries to establish the MDRR?
I'll go ahead and answer the governance part of this anyway first.
Okay, go ahead.
Yeah, it's a good comment, Wojciech, about what we're talking about here. As an OHDSI evidence network, data partners have agreed to share their aggregate summary statistics about their data to the coordinating center, explicitly under a protocol that states that the data will not be identifiable for individual sources, but they will use this information to try to learn how we can facilitate network studies. So it's under that OHDSI evidence network protocol that's posted that we've conducted these analysis within the central coordinating center. Ultimately, if we want to run research on the network studies, that is a matter of using the network, the evidence network, to reach out to those sites, identify sites that we want to participate and engage them. Here, what we're really just trying to do is demonstrate, as it relates to the original OHDSI evidence network, how the data can support the methodologic research that we want to facilitate as a community.
Yeah, and the quick comment to Cindy. So excellent result. I tried to do it quickly in the SNOMED CT browser. Has anyone bothered to submit the NIAD as a thing to SNOMED CT, at least US extension, such that, like, what I found the most troubling is that the 40% of the existing code are not what we are looking for. So I'm hoping since 2024, at least one informatician other than me had this thought of submitting it to SNOMED CT.
Great thought, thank you. I think part of the issue is that at least at institutions, these codes are being coded in ICD first. So I think we need to go to ICD first to get a specific code for NION and then work on SNOMED. No, at least, I mean, so we see the ICDs are often not granular enough, and we have this king of terminology called SNOMED CT. So we should go directly to the king, I think. And there's an established mechanism, right, to submit that. So if not, I would be happy to volunteer to submit, not during the government shutdown, it will get delayed, but because it's NLM. But I have submitted, actually, I fought the battles. It's not that easy, but please do submit that because we will increase a different type of accuracy. I would say informatics smartness about our future, real-world evidence. Great, thanks for the comment.
Right. We got 30 seconds left. One more question.
Okay. Not too loud. So apologies, newcomer to OHDSI. So this question might be something that a lot of people are already familiar with. But earlier in the presentation, we were told that even with all of the databases that we have scattered around the world with, I think it was 14 countries, something like that, we don't have enough to make a lot of confident claims about a lot of drugs. So I'm really curious about, I'm from a computer science background, I'm curious about how we're planning on expanding that. Because I know that the CDM model is very thorough, very, very big, so it's hard to adopt for a lot of countries. Is it going to be for the short term to reach out to more institutions in the existing countries and over time to try and expand to more countries around the world? Or do we not have a plan quite yet?
Well, yeah. So just to be clear, so currently the numbers that I showed are from the OHDSI Evidence Network, which has 45 databases, which is a lot. But as you remember George saying at the start, I think we now have 500 databases across the world converted to the OMOP Common Data Model. So That's also why I was doing the call for more people to join the OHDSI Evidence Network. If you're already converting new data to the OMOP Common Data Model can be a lot of work, but the ones that are already converted, it should not be that much of a barrier to at least join the evidence network and let people know that your data exists.
Okay. Thank you very much.
All right, I will give you a question, but just know that you are holding up everyone from lunch.
Oh, that's okay. Thanks. Thanks so much. Kristen Schneider, University of New Mexico. I come from a math background. Okay, and there's also the statistical concept of consistency, which essentially means you converge in probability or almost surely to the true parameter if you increase sample size. So I'm wondering whether you can comment how you can use network studies to actually combine sample size and increase sample size to align more with this statistical definition of consistency.
Well, so I think the study that Cindy, or at least the situation that Cindy described with literature, where the tau was just high, there you already know that the more data you're adding, you're not going to converge towards an answer other than that you don't know. So I'm not sure if that is the situation that you're describing, but certainly we thought about having like a rubric where you do a study and then you find you don't have enough data and then you go out to collect more data. But we decided against making that a recommendation just because then you're also starting to move into the area of p-hacking. So that's why we recommend beforehand plan how much power you need and how many databases you should have so that you have a single answer that is immediately your final answer. So I don't know if that answers your question.
It's kind of long. So let's follow up on that.
Yep, sure.
Okay, so everybody enjoy the lunch.
Very good. Thank you all very much.